Everyone, so on behalf of Team AIOS-ARC, I welcome you to this third session of AIOS-ARC Training the Trainers program. So I'm sure this promises to be yet another very informative session where we have teachers from all over India giving their insights and inputs about how they go around their teaching and imparting knowledge to the younger generation. So I welcome the chairpersons, Dr. Samar Basak, Dr. Elena Kumaran, and the panelists, Dr. Subina Narang, Dr. Sumitra Mohapatra, Dr. Aprajita Chaudhary, Dr. Inder Rastogi, and Dr. Rakesh Shakya. Thank you all for being here. With that, I move on to our first speaker, Dr. Deepti Joshi, who will be talking to us about the initiation into clinical teaching, clinical learning.
Thank Prashant Pavan sir and the team ARC for this wonderful opportunity. So my topic is initiation of clinical learning, and so through this talk we would be at the end we would be defining the specific goals and what would be the outcome to how we would be initiating this clinical learning, especially for residents, trainees and the fellows. So why exactly is this topic? When I got this topic 3 days back and I went through few of the literature search, all the initiation of the clinical practices studies are in 1980s. It's only in the recent 2013s and 14s that there is a resurgence of the interest in this ophthalmic education. Why is it so? Because the curriculum has changed, the amount of knowledge and the technologies which we had been using has changed, and hence the inculcation of the various learning techniques have changed. And we need to include all the novel education strategies, especially after the COVID-19, when the patient education and the direct contact with the patient reduced. So one of the studies by Zhang H. said that most of the students said they were having teaching in the clinics in the form of lectures, but they preferred teaching in the form of hospital tutorials, which they actually had during the UG days. So then what the ophthalmology department did, he actually went through whole of the Australian 56 medical colleges. He did this change where he inculcated clinics-based live cases and demonstration of examination techniques by the subject experts. And what was the result? The positive impact was on the amount of knowledge. The average pre-test and the post-test scores changed from 40% to 76%, and this p-value is significant. So now this in Australia, what they did, they went around and they did clinics based on live cases. Can we do this in India became the next question. Well, most of the surgeries in most of the institutions as well as medical colleges have become a daycare surgery nowadays. Do we admit any patients? Well, that is hardly maybe 1 or 2 of the corneal ulcers which we get, or maybe post-op cases which we wouldn't let our fellows or postgraduates to touch them. So that is one point where actually the patient efficiency for the clinical learning. Second thing is patient demands and ethics. Lots of the patients who come to our OPDs now refuse to get touched or even examined by a junior doctor. They want themselves to be seen by the senior doctor as the first setup. So with these two barriers which are happening in most of the OPDs, how do we go ahead with the clinical learning? And that is where the newer technologies, newer advances of the clinical learning has come, and that is simulation-based education and the technology integration to help the children, especially our students, postgraduates, to learn. Research has showed that most of the medical students have skill retention of only 3 months post-training. So we have to increase this skill retention in them, and that is where the simulation-based education and technology integration has come. The first most important change which was brought about, all these changes are post-COVID changes minded, when the patient touching and the patient interaction with the patient went down. That is when technology got involved into the clinical learning. So there was something called as Zimbabwe Retinopathy Telemedicine project, which is done in most of the Indian scenarios also. That is, a person goes, he takes a photo, a trained academician goes, he takes a photo of the retinopathy of the prematurity and then he sends it. But these were being analyzed by the postgraduates and the fellows, along with their assistants. So they used to see each and every ROP photos which helped them in the clinical evaluation, and later based on the MCQs which were projected for each of the ROP photos which were being taken in the periphery, they were analyzed within those 1 month of their training as to how the improvement happened, and this they called as Zimbabwe Retinopathy Telemedicine Project. The second one is digital learning. Same thing has been done as a Gen ROP. This Zimbabwe ROP study has been included throughout the world as a global education network for retinopathy of prematurity, where this Gen ROP holds their own website where fellows and postgraduates can enroll themselves from any part of the world, and a mentor sits at the other side, mostly from the US or Canada, and a live discussion does happen with respect to case-based scenarios as well as the photos, where the students get to learn clinically as to what they are seeing and what would be their way of management if they see. The next is the virtual ophthalmology clinics. So what is virtual ophthalmology clinics? Where they get to see patients initially in virtual mode, the animations, the same clinical features what they would be seeing in a patient is being projected virtually. Followed by that, the MCQ start, and then when they answer, based on that the pre-assessment and the post-assessment happens. So the advantages are many. There is a digital enhancement, flexible learning opportunities. Multiple people from all over the world are sitting in that virtual ophthalmology clinic. So you get to discuss with multiple students, you get to hear their answers. There are 4 to 5 mentors of that specific subspecialty who are actually teaching you clinically that this patient may have this. So instead of just learning from one mentor, virtually they are getting to learn from 3 to 4 mentors sitting at home. But then what are the cons? There are multiple cons too. It requires reliable technology access. The distractions can be challenging to some learners, and over dependency on the digital. There are some other cons which I'll come in the last part of the slide, last part of my slide. And then the virtual reality. So this is the newest one. When I actually searched through the internet, I realized my own subspecialty, that is for the pediatric ophthalmology or the strabismus, where a learning is difficult without being able to assess strabismus. There is something called as strabismus emulated avatar humanoid simulator. It is being designed by Korean and comparatively slightly expensive, but then those postgraduates or the fellows who can really afford it, it does let them do digitally how to perform a cover uncover test, how to do a prism based measurement of the strabismus, and then a third person view is also present where the teacher can sit and assess them if they are doing a cover uncover test perfectly or are they doing any mistake. It gives different, in fact I went inside today into this, it gives paralytic strabismus, comitant strabismus, restricted strabismus. A person gets to do clinical examination of a patient virtually sitting at his own place of different type of strabismus. So, and this they did on 14 students, and they saw that there was a significant improvement in the strabismus assessment score from 22 to, from score increase from 15 to 22. So this is definitely 100% improvement in the clinical learning. So online there is CyberSight, there is AO. Orbis has a virtual mentorship where you can pay for one mentor of one subspecialty to take care of you throughout your next 2 years, and he would be teaching you all that is happening in his own country. And Ingenuity 3D training happens for surgery online in Armenian Eye Care project, but this is surgical. My topic is only clinical, so I have not included much. So in this all this world of digital learning of the clinical, can the technology replace our learning, what we had learned long back, or what we as mentors can teach? Can the soft skills, but we have to remember that the soft skills can never be replaced. I think there is something which postgraduates will never learn from AI or technology, that is empathy, the lateral thinking and the problem solving ability. There was one child who used to come to me every 3 months as a headache repeatedly. I did an MRI, I did all the possible investigations, everything turned out to be absolutely normal. All it required was the probing of the child. One day I sat with the child for 15 minutes and the child opened up. Only when I say headache, my mom and dad stay back with me at home. So the child, when she used to crave for her parents, she used to complain of headache and she used to land in my OPD. So this lateral thinking, problem solving ability cannot be taught virtually. and the communication skill, breaking of bad news. This is something which really definitely cannot be taught by technology wise. And finally the counseling. When we do, as a pediatric ophthalmologist, when I do squint surgery, 100% there is 30% ratio of under correction, over correction. And when my postgraduate assesses, my fellow assesses it beforehand, how he conveys it to the patient about the under bar over correction is what is most important thing we need to teach them for their future. And these things can never be taught by any communication or by any technology. So to some extent in any clinical learning, us mentors or teachers can never be replaced. So our role still remains despite all the post-COVID technology. So with this, I would like to end with telling that for the PGs or fellows, tell me, they forget, they teach them, they remember. But when we get involved and they get involved along with us, that is when they learn. Thank you.
Thank you, Dr. Dipti, for that very informative talk. There were so many new things that you showed us. And what you highlighted in the end is that virtual teaching can never replace physical teaching. So one is the present day PGs are lacking in the emotional quotient which needs to develop, and I think that can only be done when they are with a group and learning together with their peers and also with the teacher. And there's so many verbal, and non-verbal clues that you pick up when you're interacting with a patient, which you cannot never do when you're in a virtual mode. Thank you so much. Thank you. Any comments?
Dr. Girish Rao.
So our next speaker is Dr. Girish Rao, who will be speaking on maintaining a logbook and why. So his is a recorded presentation and we'll be playing it online. It's online?
To thank the AIOS for this
thing where AI is taking the place, but bedside teaching can never be replaced. The patient touch, patient talk, patient behavior, how you talk to them, that cannot be learned from AI. So that is the utmost thing. You can be aware of the disease, you can know the problem, but the patient touch and how you take the decision at the moment, that can never be replaced by the AI. Yeah.
The first thing we are taught is history taking. That itself, if we follow a protocol, we are going to miss out certain parts of the history that also.
It does have its advantages also, because they get to see such a plethora of presentations virtually which they would not be seeing in a regular clinic. So I think if both the modalities supplement each other, that would be a very happy space. So I think it's very good that the present generation has access to these technologies which we never did. And like you said, there are so many mentors that they have access to. We have webinars now, international, national. In our times, we could never even think of interacting with those people. So I think it's a very good time for the students, and they should make the most of it. Both the technology is available and the physical. So what I'm seeing is a drift towards, just the techno. They're not into the clinics. They hardly ask questions now. They hardly come up to you because they know everything is digitally accessible. They hardly interact with the patient, they're not very keen on examining, in depth. So, but I think they should utilize both the mediums and enhance their clinical skills.
What is the cost of that simulator sheet?
I just put as content trial and it gave us free. I think next if I press it as pay, I wanted to try today before I actually put it. So I just put it as a free trial, and that's only for 24 hours. It comes something in Korean currency which I have to convert and see what. It's by the Korean, so I'll do that and let you know.
So we are having holograms of patients. So
true. In conferences, we have seen that residents come only for their session, and you don't find residents anywhere else because they feel that everything is available on the net. So somehow this has to be, they have to be made to realize that it is not that everything is available. If you have come for the conference, you should be in the sessions because you are getting a direct one-to-one teaching. But you don't find them anywhere. Right? They'll do their presentation and they'll just disappear.
So this needs to be emphasized. I think we are ready. So.
Good afternoon, friends. At the outset, I would like to thank the AIOS for this kind invite to be a part of this prestigious meet. Unfortunately, due to pressing commitments back home, I am not able to be present in person for this meeting. The topic given to me is the importance of logbook. As Benjamin Franklin has said, tell me and I forget. Teach me and I remember. But involve me and I learn. And this learning is for life. And that's the key for a professional development as well as accountability in our job. So what is a logbook? A logbook is like any other book which captures all that we want to pour into it. So we need to have a specific purpose for which we are capturing this logbook. The logbook for different people will have different importance. It could be the security person at the entrance of the hospital maintaining a logbook of the people coming in and out. Or it could be the housekeeping person keeping a logbook of the date and time of what the cleaning manuals and the cleaning protocols that he or she does in the specific area. Similarly, for a doctor, it could be a logbook of the patients that he or she has seen, treated or operated upon. And this can be preserved either in a paper form or a digital form. So through this presentation, we'll try and see the importance of maintaining a logbook, what are the benefits for the residents and fellows in particular, and also please see some of the best practices in an effective logbook management. So now, the importance of a logbook can be from the statutory point of view as well as from an individual point of view. From the statutory point of view, obviously documentation of the training is important, especially when a resident commits or a fellow commits to a few years of his life to a particular training program. It is but expected that at the end of it, both the parties benefit out of it. The resident from having had a skill upgrade as well as the institute having a trained person help them in the day-to-day activities of the organization. So you could record all the procedures and the experiences time-wise, and over a period of time, this can actually serve as a way to track the progress that he or she has benefited in the system. It also brings about a sense of accountability, so that each institute which has its own protocols and do's and don'ts, this would in a way help in monitoring that one adheres to the protocols of the organization, and in turn would help in the assessment of the individual. As I said, there could be institutional requirements, especially if this program is conducted as a part of a university or the DNB or any other accredited bodies. They would like to, at the end, monitor the uniformity of training across all the centers and across all the individuals or the candidates. And that's why there is a regulatory requirement of the maintaining of logbooks. But more importantly, it also helps your mentor, your faculty to monitor your progress as well as judge you as against the standard, the minimum requirement standard in the system. And each institute also at the end of the term also has the best outgoing resident or a fellow, and this would be a very important document to grade this person's performance. And this is something which can be quantified rather than being a very subjective assessment of what I feel or what somebody else feels about a particular individual. So one of the best practices of maintaining a logbook would be to have regular updates, and this is something which is very easy to say but very difficult to adhere to. Ideally, it is best to have these inputs done as and when you see the patient. So you see something very unique in a particular case and in a particular person, it's best to jot it down at that moment itself, because if you end up in a typical OPD seeing about 50 to 60 or even 100 patients, it's very difficult to remember what exactly was that particular clinching point in a particular patient, the slit lamp finding or a fundus finding or the history, something that made you think differently out of the box. So if you are able to capture that in your day-to-day practice while you are on the job, that's the most ideal, and that's why we encourage our residents to always carry a notebook. So they can just scribble it in between when the next patient comes in. They can always update it at the end of the day with more details. So if that is not possible, then at least weekly there needs to be an update into the logbook, because as I said, you might think that you remember this for life, but when you see a number of patients on a daily, weekly or monthly basis, you tend to forget that particular standout feature of a particular patient which made an impression for you. And it's always better to, when you record the complete details of the patients, including the dates, the patient's identification in terms of the medical records that you can trace back, and also what was done for that patient in terms of procedures, investigations, or the surgery. And there are apps and technologies which help you in capturing these, but you need not need a very sophisticated software. I think a simple notebook or your laptop is all that is required for these updates. So, as I said, like in everything, you need to make time for these things. You know, there is only so much that you can do within a 24 hours. In addition to maintaining all the requirements, statutory requirements of the organization, your mentor, and having time for yourself, there is a difficulty in doing this balancing act of maintaining the logbook, and generally logbook tends to take a backseat because you have other commitments where timelines have to be there too. But if you are able to juggle your time slots and get time for these logbook entries, there's nothing like it. And if you can maintain this consistently, not just during your 3 years of residency or 4 years, but even later on in your practice, that would be the most ideal outcome. And obviously what it does require is how you do your time management, how you do your multitasking, so that you give equal importance to all the work that you do within the 24-hour time slot. And so I'll just show you a couple of examples. What we see at the end of fellowship program when we ask our fellows or the residents to submit their logbook. This is typically how they would maintain it in terms of the patient demographics, the diagnosis, what surgery was done. This is the surgery logbook. And then during the fellowships, they are given initially steps to do, and then in a graded manner, they might even do individual independent cases for the free patients or so on. So they are expected to. It's not a surgical note, because a surgery note doesn't tell you anything. You can just say that vitrectomy was done, PVD was induced, oil was put, and the laser was done. There's no learning here, because that's what anyone can capture that. But if you can document what you had, the problems, or what was something very standout in that particular case, as well as if you're lucky enough to have your mentor on the side too, and if he or she is able to guide you in terms of your handling of the tissues, your handling of the instruments, your thought processes, how you maneuver your light pipe, the forceps, the chandelier, the various armamentarium that you have during surgery. I'm talking really from a posterior segment surgery point of view, but it could be for any surgery. When you're doing a phaco, how your settings of the machine, the entry that you make, the instruments that you use for your taking care of the nucleus, how you protect the posterior capsule, the endothelium, or in a glaucoma surgeries, the identifying the Schlenz canal and doing all the kind of procedures that are done. So if you are able to identify each particular case, that one particular little learning is what this logbook would capture, and we encourage the residents to get this countersigned by their mentor with whom they are posted for that particular week or a month or that OT. So this way the mentor also can give additional points what he or she feels were the learnings or what were the shortcomings of the individual. A more detailed could be this kind of logbook where you actually also have the pictorial representation. So what was the pre-operative fundus diagram, and if there was an ultrasound or any other investigative modality that was used. And then the intraoperative actual drawing of what was done. And as I said, this is then signed off both by the resident as well as by the consultant. So in addition to the actual steps, it also highlights what are the learning points in that particular things. And I cannot overemphasize this importance of the learning that a person will get from this. I sometimes refer to my logbooks which I have done way back in the 97, 98 period. And it did help me, especially when you are kind of stuck in a particular case, especially if you are in a private practice. And there's not much that you can fall back on intraoperatively. So at the end of the surgery, you can always, go back to something that was done earlier. Or in anticipation of a difficult case, if you actually go back to your logbooks and try and see what was done, and in the cases where you have done individually or where you have assisted, it can give you clues and steps in which you can probably better prepare for the expected intraoperative difficulties in a case. As I said, this also can be maintained in the logbook in the digital form. So it makes it a little more elegant and you can, in addition to actually writing down what are the difficulties, you can actually, especially if the case had an intraoperative event, like in this case, you can see very clearly the lens touch that happened. So while doing an aggressive base excision in a picky patient, unfortunately this resident ended up creating a lens touch, thus necessitating an additional procedure, that's a cataract surgery. This could be done in the sitting of the subsequent sitting, that's the other point. But the learning from this case, like being over aggressive in doing a base excision, especially in the opposite quadrant, 180 degree apart, is where you're most likely to end up with this kind of. So you have to be very aware of the case that you're doing. What's the eye in total? You're not really looking only at the retina or the optic nerve, but you're looking at the eye holes, what's happening in the conjunctiva, the sclera, the cornea, the lens, the angles, everything needs to be. So these are the kind of learnings which can also be stored very elegantly, and for you to go back and revisit them, so that it actually helps you in improvising your skill sets. So in conclusion, as I said, maintaining a logbook in addition to a year or every few years, and how you have achieved better results both for the patients as well as for your own clinical development. And it's very important part of the professional growth of an individual. So I encourage everyone to very proactively maintain a logbook, and more importantly, get it vetted by your mentor or the faculty, so that whatever you have learned in that particular case, be it in the OPD or the surgery, is also countersigned by them and with additional inputs from them. So once again, thank you for this kind invite.
Very excellent talk indeed, and I thank Dr. Girish Rao, though he's not here, but our thanks to Dr. Girish Rao for that wonderful presentation. Well, logbooks, of course, are a very excellent communication tool between the trainees and the teachers. However, logbooks are not optimally utilized in our clinical settings. Most often it's just filling up of the different columns, it's just a formality. So the students don't generally write the points that Dr. Rao highlighted. And of course, logbooks give us a very quick understanding into what's happening with the trainee, how far has he reached his goals of training. And the excellent examples that were shown to us, I think we should all incorporate those into our... So, we have with us Dr. Namrata Sharma, and we thank her for her presence, but she's taken out time from a very busy schedule. So Dr. Namrata Sharma will be speaking to us about how to get the best out of my PGs, key pearls.
So thank you Tinku. I would be talking to you about how to get the best out of my PGs, and this could be in the form of all the skills that the postgraduates are supposed to acquire, such as clinical skills, surgical skills, research caliber, thesis, pursuit of publication, and adapting to technology. So I think clinical skills, one should be, like Tinku was also talking about, a logbook. All the postgraduates should maintain a logbook, whether it is for acquiring clinical skills or surgical skills, and generally they should be well versed at the end of residency with the training of these things which are shown. And this is the basic minimum, but there can be much more than this. All these examination techniques like slit lamp examination, direct ophthalmoscopy, tonometry, orthoptic, gonioscopy, stereo acuity, contact lens evaluation, etc. Timer. Apart from, I think, the clinical skills that are there, case presentations and ward round, I think, play a very important role, because if there is a ward round, then it's like a bedside teaching, and I think that still holds true for now. We all in our postgraduates learned on ward rounds and bedside rounds. In the recent times, this is not the norm, but I think that is again the best form of teaching, and I think you learn most from your immediate seniors. So maybe your senior resident can teach you much more than what your consultant can teach you, because your residency is not there and you can ask him or her anything. Then there should be teaching tools. Just to show example, that when you are seeing the patient on the slit lamp, actually if it is linked to a video or linked to a camera, then you can actually explain on the camera itself what the lesion is and what the pathology is. Of course, the student should know how to handle the key instruments and not be dependent on the optometrist to handle the instruments. Decent etiquettes and communication skills are very important. Conversing with the patient, making the patient comfortable. This is also part of teaching, and I think that the students, they learn inherently from their teachers. So you have to set a role model and example for them because they would imbibe the way you are dealing with the patient. Then simulators do play an important role, and it is said that you should not be jack of all trades, but I think at the level of the post-graduation you need to be jack of all trades to actually also choose later on what you want to master in. So these are just examples to show that it is important to learn surgery, but it is also important to learn the way we are going to diagnose by using the technology. Now, as far as the surgical skills are concerned, there are some surgeries which the postgraduate should be knowing how to do, and I think cataract surgery is very vital. Some surgeries which they may assist, they may actually not do, like retinal detachment surgery or keratoplasty. And some emergency surgeries where they should be able to do it, like repair of corneoscleral perf or corneal perf, because all emergency surgery should be known by them. Then the surgeries can be learnt on, again, animal eyes or goat eyes, as is shown here, or on a surgical simulator if it is available. Nowadays, every conference has a wet lab. AIOS headquarters has a wet lab which we established 3 years ago, and also in various hospitals and in the various centers, the wet lab courses or the dry lab courses are being held. And this is a good tool before you actually start doing surgeries on the human eyes. But I think as a teacher, it's a different way of when you actually make them learn on the goat eyes or pig eyes. It's a different way of doing surgery, and sometimes you also have to relearn as to how to teach them on animal eyes. There are setups which are organized, such as seen here. This is the RP Center Wet Lab, where we do have a monitor, and we do have we can actually monitor not only by the side piece but also on the computer monitor to teach the student where he is going wrong and how it should be done. But I think one thing should be very clear: it is always very difficult to do surgery in animal eyes as compared to in human eyes. Because their positioning, their handling and their stability is important, and that is completely different. This is teaching in surgical simulator, and I think VR surgery simulators, phaco simulators. There's a simulator by Help Me See on SICS. They are again good tools for getting the hand-eye coordination, getting the general reflexes of how to do a surgery. Then we do have in our OR or OT RP center, we have all the operating microscopes connected to the cameras, and so for us it is like doing live surgery every day, because when you are doing surgery there is a whole lot of the entire OT, your residents, the nursing staff, everybody watching you. So it's like doing live surgery daily for each and every case. For postgraduates, it is important that you make them assess the cases so that they can observe by learning. Even if the postgraduates edit the videos that you do surgeries on, I think it's a great learning tool or experience. I myself have learned phaco surgery editing other people's phaco videos. And when I did phaco surgery, I didn't have a learning curve because I actually knew how to deal with whatever can go wrong. So goat size, I think, is something which is underutilized. You can do small incision cataract surgery such as this. Then you can do phacoemulsification, which is being shown here. Then you can repair, make a perforation and then pretend to repair it by using 10-0 monofilament nylon sutures. Dr. Amar Pujari from our center has shown that you can even do squint surgeries using goat eyes if you have the whole globes. Then even all kinds of surgeries actually can be done, and like I said, live viewing again helps. This is just to show the RT view that we have, and it's a big screen and it's a 3D view, so the students, if they wear the 3D glasses, can actually see what is happening in a 3 dimension. So again, like I said, some of the surgeries you have to skillfully know before you finish your postgraduate. So I think as a teacher, it is our duty to make them learn these surgeries by doing, preferably, and if not by doing, then at least getting them to assist. Handling machines is a different ball game, but it is something that should be known. Sometimes these machines are available at your center, and so you can ask them to use it. At other times they may not be available, so please arrange in a nearby center where they are available so that at least they can go for a demonstration. Even the company people or the manufacturing people can get these machines for demonstration purposes to your center or hospital, and they do have demo pieces. Handling of these machines is important, but nowadays the technology has advanced so much that these are more handled by optometrists than by ophthalmologists, but nevertheless we should know the interpretation of these investigations. So again, the residents are expected to be familiar with this, at least keratometry, perimetry, pachymetry, FA, OCT, A-scan, biometry and corneal topography before they leave. As far as research is concerned, I think all of them are going to do thesis, and when you do give them thesis, you have to tell them the clinical relevance of the topic, devote time to the students for their thesis, analyze their documentation from time to time. Generally they have a tendency to come in the end and show you everything, but it is important that at least a quarterly audit or revision should be done. Otherwise, sometimes there are so many new things which you also can pick up and you've not thought of putting it as a parameter, and as the thesis go by, then these things can be done. And I think thesis is basically etiquette that has to be inculcated, because it goes through everything: statistical analysis, ethics committee approval, protocol writing, putting the references. So it it teaches the student as to how to commence research and do research. This thesis I put because this was the thesis which I did with my student Dr. Priyadarshini, and our publication in first go got accepted. Some of the thesis students are really very, very diligent. So this was our publication, and we didn't have to do any revisions also for that. Everything was done by her. Of course, the surgeries were done by me, but record keeping, documentation, assisting in the surgeries. And as a result, when she did become a senior resident, her learning curve for all these surgeries was markedly shortened. And of course, I think it is our duty to help them to prepare for the exams also, whether it's a case presentation or it is a surgical. Some places like ours, they have to even demonstrate their surgical skills. So it is important for us to handhold them and to help them to prepare for the exam. And we have to teach the mentees, of course, other etiquettes to be, regular, to be very careful about their clinical findings, about the consents. And I think this is what we don't teach them, but we should. The financial skills, the medical ethics, the medico-legal matters, the communication skills, and last but not the least, stress management. So, the hand-holding or proactive learning is the way to go for the postgraduates, and we should do them as far as possible. These are the books which we actually wrote based on the feedback which was given by the postgraduates to us, because they wanted to do a reverse book where they wanted to know how the cases are managed rather than how the theory is given, and then the theory they have to, otherwise they have to mug it up. So the case presentations are given in these books, and what investigations to do, what surgeries, etc. are being taught to them. So thank you very much for your kind attention, and if there are any questions, I will be happy to take them.
Thanks a lot, madam, from someone who has been handled by you.
Thank you, Ellen.
And I want to comment on that last thing which you said, we are not teaching. This is what happened when I left ARC Center. Senior residency, I went to madam and complained I have not learned anything regarding private practice. You know what she did? One day, she took me to the next speaker's clinic, left me for a day. And the next speaker, right from cleaning the floor, she taught me, Dr. Mohita Sharma. That's the, thank you.
Thank you, Ellen. Thank you.
Thank you, ma'am.
We call upon the next speaker, Dr. Mohita Sharma, ma'am. Monitoring.
Mentoring. So this
Mentoring.
a mentor is someone who sees more talent and ability within you than you see yourself, and the mentor is the one who actually helps you to draw all those talents out. And Dr. Mohita has been a mentor to so many people, so many women. She runs the very successful Women Ophthalmical Society, and she'll be speaking to us on mentorship, her take on it.
First of all, thank you, Dr. Ellen, for acknowledging. And yes, I taught you first thing how to clean the OT floor yourself, because you should know first, because then only you would be able to monitor your staff. So I'll be talking on mentoring, my take. Now, frankly speaking, as Dr. Ellen has already said, I have for many years been only a private practitioner, a totally commercially driven private practitioner, with no experience of teaching and no experience of mentoring. But as your practice grows and it becomes into an institute, you have fellowship, you have fellows, you have trainees, and somewhere people start calling you a mentor. And for me, it was a life-changing experience with Women Ophthalmologists Society, where many women started saying, I'm a mentor. And so I went back and introspected as to why they are calling me a mentor, and if they are calling me a mentor, how a mentor can be better. And that is what I want to share with you, what I learned and what I feel mentors should be. Now, since this is a subject which is very close to my heart now, so my initial slides are all a little philosophical, so bear with all those philosophical, and then I will go on from each slide. What is the message that I want to put across for mentoring, my take. For the mentees, you are no ordinary people. You are a soul on a mission. When you really want something, it's because that desire originated in your soul. You were not born to be mediocre and ordinary. When you start walking on your journey to learn, you soon become a part of the crowd. Learning takes a backseat and a crowd or a herd mentality rules. Being a part of crowd is an easy way out, but it also makes your soul suffer. This can change the day you meet your mentor or a teacher, and this is the date in Samara. It is a day that is written in the stars, a date with destiny. Everyone who starts out is at ground zero to begin with, but how they end up can be shaped up by a mentor. A mentor awakens the sleeping language of your soul. What your mind can conceive, your body can achieve, and your mentor makes it happen. The mentor makes it possible. Whatever you want, that mentor will make it possible and is a guiding force for this. You have to work hard every day, bit by bit, and you will see yourself growing exponentially. And in that path, when you feel yourself feeling low or depressed or confused, you can reach out to your mentor, and the right mentor would be right there by your side at any time of the day or night. Running away does not solve a problem, it only increases the distance from the solution, and the right mentor can give you the solution for every challenge. You have to take the criticism in a positive way, and when you take criticism as a gospel truth, because it is coming from your mentor, you will go towards positivity. So you have to become an extraordinary ophthalmologist. Uniqueness is your essence, which you have to rise above the ordinary. And when you reach there, you have to remember to help others who are still struggling on the way. What happens when we are teachers? We forget what it was like to be a student. We expect results. We forget the anxieties, the jealousness, the insecurities, and we have a lot of expectations and we expect results. So we have to remember that it is always a give back time for mentors, and we have to believe in the concept of givers gain, which means the more we give, the more we get. Now my topic, mentoring, my take after these philosophical slides. Let's see the first slide. You are no ordinary person, you are a soul on a mission. So my take for my mentee is that I always try to make my mentee believe that as a mentor, and I feel that every mentor should make their mentee believe that they are meant to be extraordinary people. We are not born in this world to just eat food, sleep, get up, do our work, and then again sleep, and then get up again. We are meant to do extraordinary things, and the day your mentee starts believing this, your mentee will do very, very well in life. So you have to make your mentee believe that they have to become not just extraordinary surgeon, but extraordinary clinician, extraordinary person, and for this they have to put in an extra bit. Second slide. When you start walking on your journey to learn, you soon become a part of the crowd. So a mentor should always make the mentee believe that the mentee should not be a part of the crowd. The mentor has to support the mentee and pull that mentee up, but also they have to make them believe that they have to master in something at least. I always believe that the mentor should tell the mentee that there should be one thing by which that mentee should be known in this world. If somebody thinks of you, they should think of something that is associated with you, and this is something you can achieve only when you master something. So for example, when I have my fellows, I ask them, you want to do a fellowship in phaco-refractive, but what is in that refractive part that you want to excel in? And they will tell me one small thing, we want to excel in this, so you should be master in that, and that's the role of the mentor. This can change the day you meet your mentor, and this is the date which is written in the stars and date with destiny. We all talk so much about a deteriorating association between the mentor and mentee, where we say that our students and our mentees are no longer respecting us. So we have to make our mentee or our students believe that you are there because you were destined to meet them. And this is something that was written in the stars, and they are lucky to find this association because you are going to bring about a big change in their professional life. Once they start believing that you will bring about a big change in their professional life, they will automatically respect you better. We will not have to force respect out of them, it will come automatically. And this is not just make them believe, we have to do it for them also. Everyone who starts out is at the ground zero to begin with, but mentor is somebody who shapes up their career. So in this, again, I would like to say we have to make the mentee understand first what their level is. Even if they are at ground zero, we have to tell them, your level is this, but now you need to come here, and this is how I will support you. Once we make them believe, they will see what was the beginning result and they will see what was the end result. You have to ask them, what is your 1-year plan? What is your 5-year plan? What is your 15-year plan? And accordingly, I will support you. A mentor awakens the sleeping language of your soul. Every person in this world has a hidden ambition. Many a times they don't come out with this hidden ambition. In fact, it remains at the back of their mind. So it's the role of the mentor to take out that hidden ambition. In fact, I remember there was one of my mentors, I consider that person as a mentor, who told me, what is your ambition? I had a small practice at that time. So I said, I want a bigger hospital. So he said, you envision that this is that place where you want it, envision that this is the hospital, then this is how it will look like. And once you do that, things will automatically happen. So he took out that hidden ambition from me, and I started working in that direction. It actually happened, and when it happened, I thanked him. So similarly, every mentor has a role that they should take out that hidden ambition from them, and then only they will be able, because every person may have a different ambition. So you cannot be just thinking in one direction and doing it your way. You have to do it the way your mentee is thinking. What your mind can conceive, your body can achieve, your mentor can make it happen. So again, it's almost the same thing as which I said in the last slide. You have to make your mentee envision, and after that, you have to make the mentee make it happen. Once you do that, you're a good mentor for that mentee. You have to tell your mentor that you have to work hard every day, bit by bit, and you will see yourself growing exponentially. You have to tell them that there is no shortcut to success. For that, you have to be an example yourself of working hard, and they will definitely emulate you. We nowadays talk so much about the younger generation where they say that they do not work hard. But once they see you working hard, they will definitely emulate. And you have to tell them also that whatever is achieved is not achieved out of a shortcut, but only when we work hard. The right mentor, when you feel yourself, when you are feeling low or depressed or confused, reach out for your mentor or reach out to your mentee. So you have to be there for all, and you have to be the go-to person. You may be a mentor professionally, but that mentee may be having personal challenges also which are interfering with professional growth, and there also you have to give your advice in a subtle way to help them reach where they reach. And when you reach there, remember to help others who are still struggling on the way. So it is your duty as a mentor to inculcate in the mentee that if they have reached there, they have to be giving it back to the mentees that they have. So it has to become a cycle. And finally, what happens when we are teachers, we expect results, and we forget anxieties, jealousies, insecurities, etc. So as a mentor, you have to put yourself in the shoes of the mentee, and you have to understand their challenges and accordingly work on them. So last slide, you have to make them feel that they are not alone in their professional journey. And my last, in fact, slide is on Women Ophthalmology Society, which is all based on mentor-mentee programs. This is the first mentor-mentee program which started around 6 years back. So it now works, or everything there works on mentor and mentee concept, and that is where I myself have learned a lot. Thank you.
Thank you, Dr. Mohita, for that very insightful and interesting talk. So you very nicely brought out the qualities of a good mentor. Just two questions. One is that how does a person actively seek out a mentor? So everyone may not be lucky. There are teachers and then there are mentors. So everybody may not, organically find a mentor. How do you actively seek out a mentor?
You may be working in an organization where you may find somebody whom you feel is capable of being your mentor. It is somewhere, it is by default that they are mentors, but somewhere you may not actually find that mentor in the organization that you're working in. I believe there need not be one mentor in a person's life. There can be multiple mentors, and these multiple mentors can be changing at different points of time. So you have to actually go out and seek and take that first step. For example, if you are impressed by somebody and you feel that you want that person to be your mentor, you may go to a conference, you may find where that person is, and you may directly interact with them. Nobody will say no to becoming a mentor, because when you put a person on that pedestal of a mentor, that person, even if that person is a selfish person and not a very giving person, will automatically come in that mode. So your requirement of mentorship may be different. It may be just that you want a one-on-one conversation on how to go about in your professional career. It may be related to your super speciality. It may be anything. It may be you have had some personal challenges and you feel that maybe another person is doing well despite similar challenges. Or it may be that you want to do a training or fellowship. So there are multiple opportunities, I feel, for seeking out for a mentor. You just have to go and take that step. Nobody says no.
Thank you. And like you mentioned, when you manifested that you would have a clinic, and when it actually came true, you went and thanked your mentor. So I would just like to add that mentorship is always a two-way street. So there are a lot of mentees, who've taken their path and gone away, never come back to their mentor. So it's very important for the mentees to always keep giving inputs to their mentor, so that he can also, feel that sense of satisfaction, come and talk to them, give them an input.
And to this I want to add, once you're a mentor and you have given whatever you wanted to give to the mentee, you have to forget about it, and you don't have to be worried about him or her coming and thanking you. There are mentees who don't come back and thank you, but it's okay, you did your job.
Yeah, that was from the mentee's point of view. And as a last question, what is there for the mentor? Like, you've been a mentor to so many people. What is there for you? Is it the sense of satisfaction? Is it what drives you to be a mentor?
I think it is our responsibility that when we had certain challenges and struggles and we reach somewhere, it's our responsibility to teach others or to give shortcuts to others. That is what is called giver's gain, which I always talk about. The more you give to others, automatically the more you will get. You don't have to sit and think that if I give, how much did I get back? But this is a rule of the world. If I give something to you, you will automatically try to give back something to me. So, but it is my duty to give. That's what I feel. And in fact, this is what I saw in Women Ophthalmologists Society, that there were many ladies who said, when the society started, this society is not needed, it's not for me. If I could achieve so much, why can't others do it? So we put them all in the mentoring role. We said, you are needed. It's not that you need the society needs you. And when they came into a mentoring role, I found that they were so much more happier, and in fact they were coming and thanking us. Thank you for putting me in that mentoring role. I realize what it is to mentor, and I realize what it is to give back, and I'm so happy about it. So it's a satisfaction which the mentor gets, because world is not about what is everything. We are all into what is there in for me, what do I get. I
can't prevent myself from sharing a few things. So one thing, it just comes to me that when Swami Vivekananda first went to Ramakrishna Paramahansa, so what Ramakrishna Paramahansa's first words were, and his eyes were closed, he said that Norentui Obosheshe Ishetish, means at last you have come. So Swami Vivekananda was contemplating that this mentee of mine is going to come to me someday. And when he came, this is what he said, and it was a prophecy. So each mentor also picks up his mentee. If you have, Mohita, if you have 10 people coming and say, Madam, please take me into your fellowship, I want to, be like you in refractive and cataract, I'm sure you're going to choose. And even Ramakrishna Paramahansa chose Narendranath Ghosh. Why? Because if a mentor mentors a good mentee, that mentee in turn will become a mentor one day and will be able to propagate everything that has been taught and even more. So I think it's also a prerogative of the mentors to pick up the right mentee, so that that time, energy, that knowledge does not go to waste and to waste.
So thank you, sir.
continue as a model.
Next session. So with that we come. Ma'am, would you like to add something?
One thing I want to say that we always have the complaint that nowadays the students are not getting to the classes regularly, they are not respecting us anything. But we have to go to their position so that we will understand their problem. Suddenly they come up with the ophthalmology PG. They have to do the thesis, they have to make publication, they have to make presentation, they have to do so many things. And apart from their only personal life. So not only teaching this thing you learn, this thing you learn, this thing you have to excel, this thing. We also have to understand their problem. And by that, we will have to be their mother, their sister, their friend, their guide. We all find that the first year student, they always ask the second year student for clearing their doubts. The second year student, they ask their senior, they never come to us. But we have to make a relation so that they will come to their problems to us. When a new person sits at a ski club from the very beginning, so we, instead of telling, we will tell us your findings, that's one thing. Then what is going on to your mind?
Rightly
By
said.
seeing these
Rightly
points,
said.
what is entering into your mind? In which direction you will go? That thing will help us. That's a very beginning
Thank you.
thing.
Thank you, ma'am. Thank you so much.
I think
So-
Rakesh is in a privileged place of churning out so many students. How do you look at it as beyond students as a mentee? What is your take on it? Because you are churning out so many fellows, so many postgraduates.
Actually, I only say one word: mentor should be friendly. I think because when I was in a PG, my mentor always actually shouting me, and so why this reason actually one day, actually I told why you are shouting me. You can give the one tip. Then one my mentor actually he's very friendly to me. He's the Dr. M.K. Rathore, and he's always told me you are the jungli, and or you are coming from the village, so you are the jungli, but you can prove yourself. Like that in the last lecture actually ma'am said, Namrata ma'am said that you should prove yourself, because you should always say the trainees your level is that and you should rise up. Thank you.
दूसरा तुम्हारा भाई भी तो जंगली बाजू में बैठा है. What's your take?
Well, it's a well-called session, and Dr. Deepti Joshi said that you are a bright child. You learn everything on the virtual thing. But then Dr. Girish Rao said, no, I will make you to teach, I will make you to read, I will make you to sit down and make the logo. And then Dr. Namrata said, okay, I will take best out of you people and let me, you should learn these things. Then after learning all these things, Dr. Mohita said, yes, now you are at this stage, we both can be on the same page and let's be mentor and mentee. And that is how the session was called out. Fantastic.
Wonderfully summed up. I think let's move on with the next session because we have to hand over the thing.
Yeah, thank you
I think we
very
will
much.
have to continue as a moderator, please.